good day, everybody. Welcome to this podcast from Asia and beyond. So, I'm Dr. Arun Bansal. I'm professor of pediatrics in Postgraduate Institute of Medical Education and Research in Chandigarh from India, and I'm honored to moderate this session. So, we welcome you all to this special Asian panel of World PICU Awareness Week. And today we explore a question that sits at the intersection of necessity and ingenuity. That is, how far will technology achieve innovation from pre-hospital to pediatric ICU? In settings ranging from remote villages to tertiary care centers, clinicians are harnessing both sophisticated digital tools and simple frugal devices to recognize, transport, and treat critically ill children more effectively than ever before. Across Asia, countries are embracing technological solutions ranging from frugal innovations to digital transformation to enhance the delivery of pediatric critical care. Over the next 30 to 40 minutes, we will hear how these innovations are shaping care in Bangladesh, India, and Indonesia, and what the future holds for pediatric critical care in low and middle income countries. So, today for this, we are joined by three outstanding leaders from our region, each representing unique challenges and remarkable progress in pediatric care, critical care. So, it's my privilege to introduce our distinguished panelists. So, it's Dr. Mohammad Chisti, who is a professor of pediatrics at ICDDR from Bangladesh. It's a diarrheal disease research center which is renowned for pioneering low-cost respiratory support technologies like bubble CPAP. Then another panelist is Professor Dr. Jayashree Muralidharan. She is head of pediatrics at Pediatric Critical Care at Postgraduate Institute in Chandigarh from India. And she has done a lot of work in telepicu and in referral app from remote to tertiary care centers. Then we are joined by Dr. Gaddafi, who is Chief of Pediatric Emergency Services at Indonesia. He is an expert on remote and interfacility pediatric transport across Indonesia's archipelago. So we'll have 3 rounds. Each will focus on patient pathway. In each round, I will pose one question to each panelist in turn. So the first round will focus on the early recognition and pre-hospital response. And my question is to Dr. Chisti. So, Dr. Chisti, in rural and underprivileged settings, what technologies are proving most effective in the early recognition and triage of critically ill children before they reach the hospital?
Oh, thank you. It actually, if you know that in settings like lower resource settings, as in Bangladesh, we know that pulse oximeter is one of the important. This is one of the important technologies, and also mobile triage tools and bubble CPAP and low cost respiratory support like other innovative issues. But I think that in this issue, I will try to emphasize on, in addition to pulse oximeter, which is very low cost, as well as it can very easily early identify the patient to identify who needs oxygen. And you know that hypoxemia kills most of the patients from respiratory problem. So it is one of the important tools that you can implement, especially in secondary hospitals in Bangladesh, as well as other low and middle income countries, which can save lives. And other important issues, the digital tools, artificial intelligence, that we are now doing this in Bangladesh, especially in Dhaka, where we are using a biosensor patch, which used to kept in chest of the baby, which relentlessly provides the pulse rate and respiratory rate, heart rate variability, and temperature, and also ECG. And by which, what we have found, we are doing this study for the last 2 years. We are in the third phase, and initial 2 phases. What we have done, we have validated this biosensor patch with the manual diagnosis of pediatric sepsis. What we have found that in pediatric sepsis, it can early identify the deteriorating features of sepsis 2.5 hours earlier than our clinicians, which creates a very important opportunity for our future um, uh, endeavor. And we have already performed the feasibility and acceptability in district level hospitals, and we have found that it is feasible. Now we are in third phase to go for the further validation. Hopefully, it will be an very important steps to identify the deteriorating septic patient where death rate is enormously high.
Yeah, thank you, Dr. Chesty. That sounds very interesting about the low cost innovations which you have carried out to help the children from rural area and how they get transported. So we'll have move on to Dr. Jayashri from India. So, Dr. Yashri, how are the digital platforms or the application-enabled systems are supporting the pre-referral pediatric assessment at primary or district level facilities in India?
Thank you, Dr. Arun, and thank you to Open Pediatrics for this opportunity. Just to put it in right perspective, the healthcare in India is divided into 3 tiers: the primary, the secondary, and the tertiary. It's a pyramid with the primary at the base and the tertiary at the top. So the flow of referrals usually will be from the lower healthcare to the tertiary care. But however, because of an unstructured referral service and sometimes patients getting directly shifted to tertiary care without being stabilized at primary care, there may be problems of overloading and overcrowding at the tertiary care. So we work in one such tertiary care, which is a very high volume unit. And oftentimes we have huge number of referrals coming from in and around the region. So in critically ill patients, we all know that the golden hour is very important. And stabilization during the golden hour is directly related to a good outcome. So therefore, it is important and probably paramount to bring all the lower levels of healthcare much closer to the tertiary care. This can easily be done by leveraging digital platforms. And one such digital initiative that has been put in place by the Government of India is what is called the e-Sanjeevani platform. It's a national digital initiative through which remote areas, doctors, nurses, as well as patients can access medical healthcare through teleconsultation services. So, in our unit, we run a remote PICU or what we call as a tele PICU facility. Through teleconsultative services, we handhold peripheral PICU and use the digital platforms to bring the lower levels of healthcare much closer to our tertiary level care. The second area where we have used digital platform to kind of streamline the referrals which come from the lower levels of healthcare is creating a web based or an application based referral process. So, this was a short temporary project that we did for about a year where we used a web based platform, gave it to doctors sitting in peripheral healthcares, and asked them to refer the patients through this particular platform. This improved the communication. We were able to get more comprehensive referrals with more documentation, and the center to which the patient is referred, like ours, we had a preliminary communication saying that so and so patient can come. So, in places, especially in low middle income countries, where there is a demand versus supply mismatch, especially with in terms of with respect to resources like a ventilator, it actually prepares the referred facility for taking care of the resources so that we can receive the patient. So, this was, however, a temporary project but needs to be better explored in the form of a mobile application. So, these are some of the digital ventures that we have done to bring the lower levels of healthcare much closer to the tertiary care.
Thank you, madam. I think these sound very interesting. The e-Sanjeevani and the referral app and the telepicu. So that's very low cost and innovative and could be useful in low and middle income countries. Now, Indonesia has its own challenges because it has multiple islands and there can be having its own problems to provide healthcare to remote island areas. So, Dr. Gaddafi, how has Indonesia leveraged telemedicine or app-based tool to assist healthcare workers or frontline providers in remote islands when faced with pediatric emergencies?
Thank you very much, Dr. Arun, and thank you, OpenPediatric, for the opportunity. Before the development of the telemedicine in Indonesia, my country in Indonesia had already established an integrated referral system. The government, through by the Minister of Health, has developed an online individual healthcare referral system. We call integrated referral system as SISROOT. The implementation of the SISROOT application is based referral with aligned with the competency of healthcare facility, the specialist doctor, subspecialist doctor, tailored to the medical needs of the patient. Integrated referral system application was developed with the aim of serving as a communication and information platform for individual healthcare referral, leveraging internet-based features, dashboard, and interoperability facilities. This allows it to interact with other referral system applications that have been previously developed. The healthcare service referral system is the healthcare delivery mechanism that manages the delegation of tasks and responsibility in healthcare service, both vertically and horizontally. Emergency cases are the situation that can lead to the high morbidity and mortality rates. And the management of the emergency patient require rapid and accurate interventions. So, from the uh, integrated referral system, we hope this situation can be uh, helpful for the patient. The problem in Indonesia is that it is an archipelagic country. We have many islands in Indonesia. And this situation, we need access to healthcare services. While some islands have comprehensive healthcare facility, but the other have limited resources. Additionally, the referral process between islands often involves sea ambulance, which are not always available or adequate. Furthermore, unpredictable weather conditions like high waves can inhibit the referral process and delay patient transfer. This is the problem. So telemedicine emerges as one of the most effective alternative solution that can be implemented. Actually, in Indonesia, telemedicine began to develop during the COVID-19 pandemic. So this application has since started to expand. When obstacles occur during the referral process, physician at the facility with the limited resources will intensive communication with the doctor in the hospital that have the complete facilities. That the hospital that have the complete facilities, including specialists and subspecialists. And the integrated referral system in Indonesia currently being in developed and combining by the telemedicine. The situation before referring a patient, the referring hospital sent a video for analysis by the medical team at the referral hospital. They also received the treatment suggestion prior to the patient transfer. Additionally, Indonesia Pediatric Society already has health application that is familiar to the patient or to the Indonesian community. Some subspecialists like the pediatric cardiology has also used this application for communication with the general pediatrician who have received echocardiography training. So the doctor, so pediatrician that have capability echocardiography based by the training will make the validity to the pediatric cardiology by this application. We currently working to implementation similar practice in the other areas, especially in emergency, inspired by the approach used the pediatric cardiology. So now in Indonesia, especially in emergency field, we follow the government system by the CIS route, and the CIS route expand with the telemedicines by the communication with the video. But actually in Indonesian Pediatric Society already have the application, but we will start to join this application. Thank you.
Thank you, Dr. Gaddafi. It's very interesting how you have connected different islands through communication and how pre-hospital stabilization is being done. That's great. So now we will move to Dr. Chisti, and we would like to learn from him about how the digital transformation and innovation has happened inside the PICU. So, Dr. Chisti, how can the frugal innovations be integrated into high dependency or PICU settings to scale the impact without high cost? So, how can we use low cost equipments in PICU to improve the patient care?
So, you know that in our PICU and high dependency unit, most of the patient populations admit with a severe form of pneumonia and also sepsis and also malnutrition. And if you know that mortality in these settings is enormously high. And what we know that WHO recommends a low flow oxygen for the treatment of hypoxemia, and this WHO and also advocates that oxygen should be considered as one of the drugs, not only the supplementary therapy. Since then, there are a lot of effort that have been made to implement oxygen, because the medical oxygen, and make the easy access to medical oxygen. And it has been found that with the WHO standard oxygen, there is 35% reduction of mortality and pneumonia. But if you see the mortality from pneumonia back from 1990 to 2024, you can see that from the 2003 million deaths, it is now dropped down to 0.7 million. There is no doubt there is huge reduction of deaths, and there are a lot of issues involved here, but the oxygen is one of the paramount important factors. And what we have found that even with these WHO standard oxygen and other routine care, in many hospitals, pneumonia-related deaths remain still enormously high. And then we thought that what is the issue here? We found that even with these WHO standard oxygen, those who come with hospitals like Bangladesh, India, Pakistan, and Sub-Saharan Africa, the risk of death 5 times more compared to those who do not have hypoxemia. And globally, in a recent systematic review by another group of Bangladesh, they found that the global evidence of hypoxemia among the hospitalized children with severe pneumonia is 31%. And in Bangladesh, it is much more higher, it is 41%. So that does mean that if we can manage hypoxemia properly, then we can reduce these deaths. Recently, we introduced improvised bubble CPAP, which is locally made, and it has been found that it is associated with 75% reduction of mortality. And the magnificent side of this is that it is low cost. And what have been shown that in last several years, we have analyzed further data in one hospital where it is part of the standard of care. It is not only associated with the reduction of mortality, it is also associated with the reduction of the total oxygen consumption cost from $30,000 per year to $6,000 per year by reducing the indication of mechanical ventilation from 35% to 7%. So this is now going to be used in other secondary hospitals in Bangladesh. You know that in tertiary hospitals we have some supports of other ventilatory support, but in um, secondary level hospitals where most of the patients with severe pneumonia and hypoxemia referred from primary care hospitals, and they are treated there, and mortality is very high there. So if we can implement those in those setting, what we are doing now, then it will be a low-cost solution to reduce this mortality. Thank you.
Thank you, Dr. Chesty. It sounds amazing to hear that how the low-cost machines have rationalized the usage of oxygen and how bubble CPAP has improved mortality. So that's something everybody should learn. So, we'll move to Dr. Jayashri. So, what are the digital technologies that are transforming clinical decision making inside the Indian PICUs and high dependency units?
I would divide this particular question into two parts just for the ease of understanding. So, the digital technology can help improve the care within one's own PICU, and also it can help connect with two or three more PICU. So, during COVID, I think COVID probably has been instrumental in bringing technology to healthcare in a great way, and probably also made all the healthcare providers adapt and adopt this technology with open arms. So here again, the Government of India initiative during the COVID pandemic was a hub and spoke model, where the Government of India created several centers of excellence, or what we call as the hub PICUs. And each hub PICU was asked to connect with multiple spoke PICUs. So this is a great form in which the PICU care can be kind of connected to another PICU, which can be either of the same level or maybe it can be of a slightly lower level. So we have one such hub and spoke model that we operate. And with the help of this hub and spoke model, we have been able to kind of create a reasonably good level 2 to level 3 PICU in a nearby hospital, which can almost take care of many things, including non invasive ventilation of all kinds and including invasive ventilation also. And when they are not able to manage beyond invasive ventilation, is the time that they refer to our center. So it's a win win situation for both the units. We are able to kind of help ourselves by not getting overcrowded. And the other thing is that when we find that children admitted within our PICU get well and just need few more maybe days of PICU care, we back refer these children to our spoke PICU. So this is a win-win situation. So this is a great way of leveraging technology, of creating this hub and spoke model. The second thing that we have done is that about a decade and a half back, or maybe more than that, we shifted to a digital database. This was a database which was kind of created for our PICU alone. And this digital database helped us in several ways. I think the most important thing was that such a system enhanced the documentation and data accuracy of our patients. It improved accessibility. Initially, there was problems of entering the data, but soon people got used to this data entry and then work efficiency slowly started improving. It also minimizes errors. And if we use it for medication and patient management, it definitely improves the patient safety, enhances patient safety. And there is a lot of cost saving which is attached to this, because this is going to be environmental friendly and a lot of paper free. From this model that we created about 1.5 to 2 decades back, a small digital database which was very relevant to our PICU, we are now shifting to what it's a larger scale paperless ICU, where just not just patient data, but medication, all management, all ventilation, all the details which are related to patients will go into this particular digital database. So this is going to definitely enhance the data security, the compliance, and it's going to be environmental friendly and definitely a cost saving initiative in the long run, and will also help us in data retrieval, research, and so many other collaborative research and other things that tertiary level PICU can aim for. And the third thing, which we still haven't started, we are still on board and marker, is different alerts, which are sepsis alerts, um, healthcare associated infection alerts, critical incident alerts, and alerts for device utilization. But I think this is a huge area which we need to explore as a tertiary PICU for creating digital dashboards in PICU for the same thing that we are doing on a whiteboard with a marker pen. This easily can be transported onto a digital database or a dashboard, which will help us in making this a more futuristic kind of um, a project. And similarly, we can also add alerts for antibiotic de escalation. So, this will also help us in antibiotic stewardship. Because antimicrobial resistance is also a huge problem in low middle income countries. So, I think three initiatives where we can easily leverage digital platforms to kind of improve the care delivery in PICU, connect to the spoke PICU, and go completely paperless and digital database, which will definitely improve the data accuracy as well as efficiency in the long run. So we are kind of a step into tele PICU. We are a step into the digital database, which definitely needs to be improved upon. And the area where we need to work on is the digital dashboards. So I think these are some three areas which I feel could be good areas to work on as far as digital platforms are concerned.
Thank you, Madam. I think all three which you have highlighted can be replicated with low cost in our kind of setup in Asian countries and can improve the patient care and also help connect with each other. So, Dr. Gaddafi, as you are having the remote islands and there are remote ICUs or remote hospitals are there, so what PICU technologies are useful in these kind of settings where the resources are scarce?
Before we discussing about the technology that are beneficial in remote hospital to reduce child mortality and morbidity, maybe we must also address the issue of the preventing delay in the referral process. Because sometimes we look the high mortality in PICU only about the technology, about the uh, how we give the treatment for the patient. But we forget it that there are the other problem that the patient before go to the hospital, maybe there are the delay, referral, uh, delay, the parents delay to bring the children to the hospital. So, technology should be utilized not only at the PICU level, but also starting from the family level. In Indonesia, many parents are still unaware of the sign of the critical illness in children, which often lead to late recognition of the emergency and delays transportation to the hospital. As a result, children are brought in a terminal stage, significantly increase the risk of the death, significantly increase of the mortality and morbidity. Therefore, education about the pediatric emergency at the family and community levels is extremely important. I think it is very important. The use of the technology such as telemedicine, especially in villages where parents already have a good answer of the health issue, can greatly help in preventing child death caused by delay in transport the hospital care. I remember today artificial intelligence very famous. Artificial intelligence will in the future play a crucial role in addressing this problem. I imagine a scenario where a mother, upon seeing her child unwell, she will record a video of the child's condition and input into artificial intelligence system designed as a tool for recognized emergency, such as the pediatric assessment triangle. And this way, the mother can immediately understand about the severity of her child condition. The utilization of technology informed telemedicine or telecommunication can also apply during the patient transportation. Healthcare worker or referring doctor can maintenance continue communication with the subspecialist doctor. Subspecialist doctor at the referral hospital regarding treatment plan before and during transfer, ensuring that patient condition remains stable and secure. Furthermore, technology can be developed in PICU too, especially at the smaller hospital staff that only have general pediatrician without pediatric intensivists, including establishing communication with the central hospital using media such as Zoom, Google Meeting, and other media, providing periodic video reports of the patient condition and receiving treatment suggestion from the central hospital that have the complete facility and expert doctor. This also includes guiding the referral process if the patient condition does not improve. In addition, several pediatric intensivists in Indonesia have developed innovation solutions such as total parenteral nutrition application on smartphone and research into interface innovation and IV. We also today conducting research on non-invasive hemodynamic monitoring using suprasystolic oscillometer. This tool like a tensimeter. So if the results are promising, non-invasive hemodynamic monitoring could only be implemented in not only implemented in PICU, but also at the primary healthcare facility that refer the patient. And it can make easy for the doctor. This will enable appropriate hemodynamic management to provide it to the patient across different level care. And the results, the patient condition is more stable, and we can decrease mortality and morbidity in patient in emergency situation. And if this patient still needed refer to the PICU, so we can make the high quality for this patient. Thank you.
Thank you, Dr. Gaddafi. That was very helpful information. So, Dr. Chisti, if we have to look at the future, what are the low-cost pediatric critical care innovation you think should be scaled and used globally, and what could be the reason and why it should be used?
So I actually want to emphasize on oxygen issue because I still feel that this is the one of the most important thing that had the opportunity to have the scale up to reduce the global childhood mortality. And for that, you know that we need to improve the access to medical oxygen by improving oxygen security, which can be done by strengthening local health system. And also, it can be done by introducing community-based oxygen therapy algorithm, and these innovations should be inclusive, accessible, and affordable, especially by making the access to functioning pulse oximeter, which is the paramount importance to reduce the abuse of oxygen and to understand what kind of oxygen we need to have support them. And also, we need to confirm the better oxygen support to reduce oxygen-related mortality. And among them, I still believe that bubble CPAP is need to be scaled up globally because of the fact that what I have said already, it is not only cost effective, but also it reduces treatment failure by identifying the deteriorating patients earlier. And if you see the evidence, there are series of evidences in Bangladesh back in 2011 to 2013. The initial efficacy trial showed that there is 75% reduction of mortality compared to WHO one, which was published in the Lancet in 2015. Since then, we have performed the feasibility trial in secondary hospitals, where I have told that most of the pneumonia-related patients died. And what we have done, we have found that it is feasible if we can address some challenges. And what are the challenges? we found both in Asia and Africa, representative country in Bangladesh and Ethiopia. What we have found that if we can afford um, a ensured oxygen source like the pulse oximeter and also oxygen concentrator, and we can educate the mother that how it can be handled very easily, then it can make it more successful. And what we have done in Ethiopian general hospitals with the supervision of the doctors and nurses have done most of the wards in those secondary hospitals, and they have the daily clinical round with the supervision of the doctors. And what we have found that it was associated with almost 75% reduction of treatment failure and 86% reduction of mortality. So from the efficacy trial, we went to the feasibility studies, and we ended up with the effectiveness study in the real life scenario, which showed their so promise. And by this time, already government of Ethiopia started this scaling up in Ethiopia, Malawi, and Nigeria in 37 hospitals. So we are now intending to scale this up globally, including also Asia. So I think that it will have a huge impact. It might have an impact, and the WHO might change their policy. And if it is like that, it can scale up by the next 4 or 5 years globally. Then it might have an impact to reduce the total global pneumonia-related mortality, and might have to attain the sustainable development goal 3. So I think that it has a huge impact, as not only as the reduction of the cost, but also as the reduction of mortality. It is the combination of low resource setting, accessible and affordable and sustainable.
Yeah, thank you, Dr. Chisti. I agree with you that low cost oxygen, low cost bubble CPAP, and saturation monitors can go a long way in reducing the cost as well as mortality in pneumonia children in LMIC countries. So, Dr. Gaddafi, if you have to tell us in your vision for uh, about the equitable PICU ecosystem in Indonesia by 2035, what will it be? What is your idea of it?
Okay, thank you, Dr. Arun. Maybe I would like to mention a small statement about the visions. I have a vision to improve patient outcome in PICU and to prevent mortality and morbidity among pediatric patients. As a pediatric intensivist, my focus not only on delivering optimal therapy within PICU, but also on addressing the broader community context. Why? Because my country is very wide, maybe like in India, but we have very a lot of the island that uh, if we talk about the healthcare facility, I think it's uh, not have very well in every places. But one area have the high resources facility, but the other area have the limited resources facility or facility. So this my vision is not only about the PICU treatment, but we have to come back to the community context to minimally we recognize about the emergency situation. This includes providing input to the government and assisting in effort to be more proactive in educating parents about the signs of critically ill in children. So late transport, late referral process we can inhibit. It also involves urging the government to enhance facility at the primary healthcare centers, especially those related to the pediatric emergency, and to ensure the availability of the referral facility, such as sea ambulance, air ambulance, and maybe the standard with the standard ambulance with the standard ambulance that uh, we have. Additionally, I advocate for the development of the referral system that is already based on the technology. Furthermore, I aim to advance the PICU first innovation that can maximize patient outcome.
Thank you, Dr. Gaddafi. So we'll also like to hear from Dr. Jayashree that advanced technologies usually are costly, and how can we ensure that these advanced technologies like AI and digital health do not cause a gap between the haves and do not haves, and especially in pediatric critical care settings, how can we take care of these inequities?
So technology has been very advantageous with respect to PICU because it has brought the global PICU community closer, especially with respect to knowledge sharing, which has been very fast, seamless, and much easier. On the contrary, when we look at PICU care delivery or the care processes, I personally feel the divide or the disparity has widened, especially because the PICU care is completely technology driven. It's hugely technology driven. Therefore, if we need to narrow this gap of how the care is delivered, for example, ventilation, for example, extracorporeal therapies, for example, renal replacement therapies, it's very important that whatever technology we adapt has to be contextual. I think that's probably the key for all low middle income countries. It's important that there has to be technology. There is no going away from it. There has to be digital platform, but we have to contextualize whatever technology, whether it is digital based technology, whether it's AI based technology, whether it's in terms of equipment, it has to be contextualized to the kind of patient and epidemiology of diseases that we see. Definitely, it has to be accessible to the population to which it serves. The language barriers have to be minimized. This is very, very important. And the most important thing is cost. Anything which is cost prohibitive is going to be a big something that cannot take off, cannot sustain. So I think the most important things for all of us who work with the PICU care delivery systems is to probably the three important words will be contextualize, sustain, and low cost. I think these are probably the three things which probably will help us in reducing the gaps, narrowing the gaps between the high income as well as the low income countries in terms of PQ technology.
Well, thank you so much, ma'am. So, in the end, I would like to ask each one of you if, in one sentence or word, if you have to give a message which you have to share with the global PICU community about equitable innovation in technology, what it would be. So, I'll start with Dr. Chisti. Just one word or one sentence.
So, our scientific community and our pediatric critical care physicians need to work more closely to create more evidences to use technology-based treatment that are transformable as an affordable and sustainable system. Otherwise, we cannot make it happen for our low and middle income countries. Thank you.
Thank you. Dr. Jayashree?
I would say look global and adapt locally.
That's great. And Dr. Gaddafi?
I think PICU without following technology, may we only be able to make our patient live, but the quality may not necessarily to be optimal. This is the point. Thank you.
Thank you so much, Dr. Chisti, Dr. Jayashree, and Dr. Gaddafi for sharing your incredible insights and experiences. From frugal oxygen technologies to national triage system, from remote island access to technology-driven ICUs. So this panel has shown us that innovation in Asia is vibrant, impactful, and deeply rooted in local needs. As we look into the future, let's continue working across borders to ensure these innovations reach every child, no matter where they are born. So thank you again to all of you for joining us in this special session during World PICU Awareness Week. Stay connected, stay inspired, and continue advocating for children everywhere. So thank you so much.